Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. Today we're going to be talking about one of the other epidemics in society's life at the moment, and I'm joined for, I think, the 5th time in the Zoom room today by Mr. Rajiv Bajekal. Rajiv, it's great to have you with us. Hope you are rejuvenated by the pause that you've had since last speaking to us.
Yes, thank you. Thank you, Stephen. Yeah.
Now, I haven't given you a full introduction. I'm hoping that most people have seen you on our show before, but of course you are a consultant orthopaedic surgeon. You practice spinal surgery, but you are one of the country's relatively few lifestyle medical practitioners as well. And today you're joining us to talk about reversing diabetes. Is that right?
That is indeed the case. Yes, it's my passion, actually. So it's my side hobby, as I said to you. Yeah, I mean,
at least 2 hobbies you've got. Last time your hobby was cooking.
Yes, I've got a few things going. Yeah. Okay, shall I start?
Yes, please.
Okay, so I mean, if some years ago you'd said to me that I'd be lecturing to a whole bunch of learned people about diabetes, I'd have said you were completely barking mad. But things change, and I have taken to lifestyle medicine. And I think, having learned quite a lot about it, I think there should be really a paradigm shift in its management. We shouldn't just be controlling diabetes, but the aim, certainly in type 2 diabetes, should be to reverse it, to cure it, and to not just manage it with tablets and insulin and various things like that.
How widespread is that approach in conventional medicine now? I hear more and more about, diet and controlling obesity and so on.
Yes, and I think, like a lot of chronic degenerative conditions in our society, this is very easily treatable by lifestyle. But till now, lifestyle medicine, which is, as I said to you, a relatively new specialty, although the condition's been well recognized for ages, absolutely ages. So in fact, I'll be talking about papers that are close to 100 years old in the management of diabetes. But people have really not listened to things in the past, and I'm hoping to change that. And I'm hoping also that it is the best lecture you've ever heard on diabetes. So here we go.
No doubt about that. I'm sure it will be.
Okay. So the aim is really not to tell everybody every little nuance of diabetes, which is very complex, and I respect my endocrinological colleagues who deal with this. But really, I wanted to make you understand the concept of insulin resistance, which is the single most important factor that leads to type 2 diabetes. And really, when your patients ask you what is a healthy way to eat, it's not just enough to say, we'll eat a healthy diet. I mean, that's a very vague thing. And I want you to be giving them specifics about what to do. And you should be able to offer this advice to at least a third of the patients you treat, because as you know, Britain and the Western society in general is in the middle of an obesity epidemic. And besides the pandemic that we're going through, which is a big disaster in itself, these underlying disorders are leading to a majority of the deaths, and diabetes is right up there. And at the end of this lecture, you should be able to point your patients in the right direction to reverse their type 2 diabetes. So if you go on to the next one, I mean, you all know that I practice with Total Orthopaedics London, and you know about our mission statement. And the reason I'm talking to you about diabetes is we as a group look at things quite holistically, a bit like you folk do. You don't want to just cure somebody's knee pain. You really want to make a difference to the patient in general. And that's what we do as a group in Total Orthopaedics. Now, obesity is really quite an epidemic in the world. So if we go on to the next one, this gives you a scale of the problem. I mean, in Britain, actually, um, 50 to 60% of the population is either overweight or obese or morbidly obese. The percentage is only marginally high in America. And it's approaching similar numbers in Australia and the rest of the world. So in Western society. Also, the truth is that if this trend persists, a third of the people will be obese by 2034, and 1 in 10 will get frank type 2 diabetes. There's a higher percentage, actually.
Can I just clarify that one, Rajiv? As it says on the slide, 1 in 3 will have type 2 diabetes. Does that mean 1 in 10 of those people, or 1 in 10 of the population as a whole, will have diabetes?
1 in 10 will have frank diabetes, yes. 1 in 3 will be either overweight or obese.
Right.
So, if you look at the number of undiagnosed pre-diabetics, there's that, is close to a third of the population. And people say it's even higher. We just don't recognize it very well. Pre-diabetes is kind of, people think it's genetics and you let it pass and you ignore it. But it does turn into frank diabetes at the end of it. So the scale is massive. And you can imagine these kind of numbers when you see the amount one has to spend in controlling diabetes.
Yes.
You're going to bankrupt society in general. So it's a massive number, really. So
I've heard it suggested by other of your medical colleagues that the concept of pre-diabetes is a convenient way of pharmaceutical companies getting more drugs out into the population. Is that how you?
Absolutely correct. And the lack of knowledge about this is largely due to propaganda by the pharmaceutical industry. We don't allow lifestyle medicine to come up because, I mean, if people ate more vegetables, they wouldn't have much to sell, really. So I mean, a simple problem is resolved by just people eating a lot more vegetables and fruit. So if we go on to diabetes is not a harmless disorder, and this kind of lays it down rather from the eye downwards. So in the eye, you can get cataract, you can get retinal damage and go blind. In the brain, you can get a higher rate of stroke and cerebrovascular disease. The kidneys can fail as a result of overwork and small vessel disease. And of course, the heart and the circulatory system can affect, well, the coronary vessels themselves or the extremities. And neuropathy is a common problem which we encounter in your world as well as mine, because you often get patients who have awful lancinating pains, radicular pains, and then you do an MRI scan and they've got nothing wrong with their back, but they have neuropathic pains that are really quite severe. And if you go on to the next one, the common causes of death, if you look at it in diabetes, the commonest cause is ischemic heart disease. And if you look at the world overall, ischemic heart disease is the commonest cause of death all over the world. It's now been overtaken by cancer in Canada, but overall it is still one of the highest. And most diabetics die through their heart attacks rather than because of their diabetes.
Rajiv, what is the mechanism for diabetes causing ischemic heart disease?
It's just associated with the metabolic syndrome. So there's dyslipidemia and they get an elevated cholesterol. They get oxidized cholesterol because the stresses from the increased sugar levels, and they get small vessel disease. So it does affect their coronary arteries also, right, in much the same manner that it affects the renal vessels or the retinal vessels. It's a pretty nasty disease, and we kind of treat it as a minor ailment. And as you can see, the second expression is because that patient has had a stroke. So that's another method by which people lose their lives. And a stroke is probably a more expensive way to die for society, because obviously you need a carer to care for somebody who's had a serious stroke. But one of the more disabling things is to get neuropathic conditions, and you get amputations as a result of not feeling anything in your foot and getting an infection in it. I'll just touch upon the diagnostic criteria next in terms of diabetes. You have to have the clinical syndrome. So you have to have polyuria, polydipsia, and unexplained weight loss, plus a random venous plasma glucose of 11.1. So these are figures that I don't expect you to remember really, but suffice it to say that there are 4 diagnostic criteria. One is a fasting blood sugar level of at least 6.1 in whole blood, or a fasting plasma glucose of greater than 7, a random venous of 11.1, but more importantly are the last 2. So an HbA1c of 48 in current measurement metrics, and the glucose tolerance test, where you give somebody 75 grams of anhydrous glucose, and over a 2-hour period, their blood sugar rises to 11.1. And that gives you a true measure of the insulin resistance. In other words, insulin is not doing its job. So let's move on to the next one. And
if I may, just to interrupt, obviously,
sure.
we osteopaths, chiropractors, we're not going to carry out those tests in our clinic unless we are also qualified to do that. What would prompt a GP to carry out those tests? Is it simply body weight, or would it be other conditions, other symptoms?
Yeah, I think body weight is the first one that alerts them. But often if patients say that they've had unexplained weight loss, or they are in the overweight category, and really this is a pretty routine test. So most people above the age of 45, 50 will have a random blood sugar or a fasting blood sugar once in a way. I mean, in America, it's much more so, because anybody who goes to a doctor gets a battery of blood tests. Here, it's less commonly done. But I think everybody who's in this room right now should be aware of there are some blood markers, at least. Anybody above the age of 40, 45 should certainly have had some parameters done, and it's usually picked up on those. Okay. But most patients will tell you that they're diabetic or pre-diabetic themselves. Yeah.
Right. I have a couple of questions from the audience as well, if I may, before we move on. Elizabeth has asked if you could just elaborate on what is meant by frank diabetes.
Frank diabetes means you have the clinical syndrome of polyuria, polydipsia, and unexplained weight loss with one of these other criteria at least. So you have to have at least one of them, but usually all 4 are present. So it's not as if somebody will have a random blood sugar that's really high, but the HbA1c, so they all go in tandem together. So that is frank diabetes. Pre-diabetes is something just under those numbers. So pre-diabetes generally is 42 to 48 HbA1c, for instance. That would give you a clinical picture of pre-diabetes. And there are various markers that indicate pre-diabetes to people.
Vladimir has also asked a question about metabolic disease, which you mentioned earlier on. He says, is there any evidence to some of the murmurings around metabolic disease, including sugar regulation disorders and the risk from this plague that is going around? I presume he means by that the risk from COVID-19.
But I think also the being overweight and dyslipidemia, dysbiosis, yes, all those are linked conditions. So it's very rare for somebody who's diabetic not to have blood pressure problems. Sorry, my dogs are going to take off because a delivery is just arriving here. So, there are a variety of things that go hand in hand. So dyslipidemia, dysbiosis, being overweight, all these things are linked to the metabolic syndrome in general.
Right.
So if we move on to the next one, I mean, you would have heard these terms. Everybody uses this. I can't eat carbs because I have diabetes. I mean, carbs is an irritating short form for carbohydrates, and it's a garbage term because carbohydrates can mean an apple to table sugar, or candies, or biscuits, or brown rice. I mean, even that is considered a carbohydrate. So it's a really bad way of expressing it. People often think fruit is bad for me because I'm diabetic. You'd have heard the thing, this is genetic, there's nothing I can do about it, it's in my genes, or I should eat less junk. And you'd have heard things like keto can reverse diabetes. So these are terms that you commonly hear, and I want to just clarify some of these myths that surround diabetes. So if we go on to the next one of the big shifts in diabetes is currently the fact that we all have access, especially in type 1 diabetes, you have access to continuous glucose monitoring. So you have this little thing that goes onto your arm, and you have an app on your telephone, and it actually alerts you to every time your blood sugar is too high or particularly too low. Now, this is a double-edged sword. I mean, it is a good thing, obviously, but it kind of gives you the wrong impression at times. So if you eat a banana, your blood sugar will go up a little, and you automatically blame the banana. But if you remember, it's only one of the criteria is your blood sugar in itself. The other bits are related to overall carbohydrate, glucose tolerance. Now, before I go on to the main body of the lecture, I just want to talk a little bit about two aspects of it, which is the first thing is something called confirmation bias. I mean, all of us have confirmation bias, and it is the sort of intersection between objective facts and what confirms your beliefs. So what you see is just that intersectional area between objective facts and what confirms your beliefs. Just for instance, I love red wine. I actually do. I enjoy it. I know it's no good for me, but I'm always looking out for literature that tells me it's really good for me. And that is confirmation bias. So people like to hear good things about their bad habits, and that's what confirmation bias is. And all of us are guilty of this. So I'd urge you to just bear this in mind while you listen to this, this lecture. And
Rajiv, there's a famous example of that, I think, isn't there? In that there was a paper published many years ago proving that chocolate was beneficial.
Yes.
And it was based on no real evidence whatsoever, but because people wanted to believe it, nobody checked it, and for a long time it was accepted as being the truth.
Yes, I mean the truth about chocolate is, of course, it isn't bad for you. It's just what all go into it. So often you get table sugar that goes into chocolate, and you get a lot of dairy, which is saturated fat, that goes into chocolate. So if you have dark chocolate that is sweetened minimally, it's not a particularly tasty thing, but you can acquire a taste for it. And that is in fact good for you. But just to move on, the other thing is something called cognitive dissonance. So it's really the fact is that people like to hear good things, as I said, about their bad habits. They don't want to listen to unpleasant truths. And if you remember, doctors who smoke or who are very overweight, they often don't give advice about smoking to others who are smokers. You know, they don't tell them to stop. So it took a long time for doctors to give up smoking or to recognize that it is harmful and start advising people. So I just urge people in general to bury their own cognitive dissonances and move on with it. Now, the next slide about insulin resistance is absolutely the key to understanding what diabetes is all about. We go on to insulin resistance. To tell you what it is, it's basically the inability of insulin to do its job effectively. So insulin's main role in the body is to move glucose from the bloodstream into the cells. And insulin resistance used to be a protective mechanism from evolutionary times when there was a scarcity of food. But now it's a problem because we have an excess of food, especially fatty and processed foods. So if you imagine in the savannah, in the African savannah, when the hunter-gatherer had not eaten for days on end and he was in ketosis, moving around looking for some food, and there was a tiger hot on his heels, he had the choice of running. Now, if you imagine the tissues in the body, actually all the tissues except possibly the brain and the RBC can utilize ketones as well as glucose. It's only the red blood corpuscles that cannot survive on anything except glucose itself. So if the muscle at that point of trying to run away from a tiger utilized whatever little glucose was there in the bloodstream, it would mean the patient would, or the person who was running would suddenly become hypoglycemic. So this used to be a factor. And because the red blood corpuscles have no mitochondria and no nucleus, they have no choice. They depend on a steady flow of glucose that is put into the bloodstream by a process called gluconeogenesis, in which the liver cannibalizes amino acids from whatever is floating around, excess proteins, or even cannibalizing old cells that are dying. And those cells are, the amino acids from them are converted into glucose that the RBC can utilize. Now, if the muscle then grabbed hold of this glucose to make you run from the tiger, you'd become hypoglycemic, as I said. So that process by which muscles stop utilizing glucose is called insulin resistance. So it was actually a protective mechanism for us. And muscles could use ketone bodies during this period of starvation. So it's a bit like a hybrid car model if you look at it. So if you think of it, when there's abundance, in other words, there's gasoline, you filled your thing with petrol, then the combustion engine just utilizes it. So the muscles utilize glucose. But at times when it's run down and there's no gasoline, you can depend on the battery, which is like the ketone bodies. And this is a smooth process of continuously utilizing energy in different forms. So if you look at the normal cell, this is a representation, and you can see here that insulin receptors, which are there on every cell, insulin acts on it to open up the gateway for glucose to be brought into the cell. And that allows for ingress of glucose into the cell. So this is the normal mechanism in a cell. If you have an abundance of fat within the muscle, which is known as, big fat globules are there in the muscle cells, and that interferes with the insulin receptors. It's like a child putting chewing gum into your lock so that you can't open the key to your, open the lock to your house. And this obstructs the ingress of glucose, and this is an insulin-resistant cell. So the theory in this model that I'm proposing to you is that if you have an excess of fat within the cell, within cells that are not meant to have fat, namely skeletal muscle or liver or pancreas, then you will have the normal mechanism. I mean, normally fat is meant to be stored only in adipose tissue. It's not meant to be stored in the muscle. It's not meant to be stored in the liver. It's not meant to be stored in the pancreas. And this is the essence of an insulin-resistant cell. So I'm just going to share with you 3 or 4 very interesting studies which have historical significance. The first is this one from 1927. So as I said, it's close to 100 years old, but nobody wants to listen to these studies really because they think it's old and outdated, but it's been reproduced a number of times. So this chap called J. Shirley Sweeney, he caught hold of 20 medical students and made them volunteers. I mean, you didn't have a choice. If you were a medical student, you were incorporated into this study. And over a period of 2 days, he either fed them a carbohydrate-rich diet, and then he shifted to a protein diet, and then a high-fat diet, or a water diet, a water-only fast, in other words. And you can see here the blood sugar values that went up. So you can see that really people were much more diabetic, in the diabetic range, if they were consuming a high fat diet. So this was the first experiment that was really quite important. And the other one is one by Rabinovich, Israel Rabinovich from Canada, did this diet. And this is pretty much like the ketogenic diet, where 50 patients were treated with calories that arose from fat. So 60% of their calories arose from fat, and 50% or 50 patients were treated with just 24% calories from fat. So more like the conventional diet that you'd see in a carbohydrate-rich diet. And you can see that insulin resistance was really much higher in people who had a 60% fat diet. In fact, in people who had a much lower fat in their diet, 57% reduction was seen in the requirement of insulin.
I have got some questions, though, if I may.
Yeah, of course.
First is from me. On your previous slide, the water diet was higher than the fat diet in terms of your diabetic spectrum there. Is that surprising?
That was surprising, and I tried to get access to the original paper to try and understand that, Stephen. You're absolutely right. I think in the initial period, and remember, this was only a 24-hour period. And on a water diet, what happens is ketone bodies are released into the blood, but there's a steady stream of the liver doing the gluconeogenesis. So I suspect it's because of that. And this is normal. This is what I was talking about, insulin resistance being protective. And it does show that the blood sugar was much higher than that. Yeah, it was a new, I couldn't get hold of the original paper, so I had to just get a summary from elsewhere, which is not normal, but I think I had to pay $50 and I was too cheap to get the original paper.
One of the other questions, which has come in actually from several people, kind of relates to that as well. Is whether you think that intermittent fasting can be helpful.
It is extremely helpful in diabetes, yes. But it's extremely helpful from a variety of reasons. One is, if you believe that what we are suffering from is dietary excess, time-restricted eating, as it's called, instead of intermittent fasting nowadays, you eat over a period of 8 to 10 hours, ideally, and that really makes a difference in longevity. So people live for much longer and better lives because it allows for the systems to rest and it allows for autophagy. So there's absolutely very little doubt that intermittent fasting is extremely useful for any of these chronic degenerative conditions that we have.
You say on this, the slide that I've got up behind me, which is your the two different types of diets, old diet, new diet, it says that 12 patients stopped insulin completely. Does that mean that type 1 diabetes is affected by diet as well as type 2?
Yes, except that, no way can anybody with type 1 diabetes stop insulin completely ever. So this was actually type 2 diabetes. It was a study on type 2 diabetes, but these were people who were taking insulin because there was no way of controlling their blood sugars otherwise.
Right, okay.
So no way would, but it is extremely useful. Even time-restricted eating is extremely useful to improve your insulin resistance in type 1 diabetes. So your insulin requirement would go down even in type 1 diabetes, but never is it completely absent. I mean, you can't get off insulin in type 1 diabetes.
I've also been asked what your opinion is. This is from a chap called Nick. Nick says, what's your opinion of the ketone diet for patients with multiple myeloma?
The keto diet is a very high-fat diet. The only place where it's medically been proven to be good is for extremely resistant epilepsy in children. It has absolutely no role in almost any other condition. I mean, these are various iterations of the Atkins diet, and we know what Atkins died of. He died of heart failure. Um, but, unfortunately, most of the people who champion it do it on YouTube or some other such method of promoting an unhealthy diet. You will see immediate benefits in certain conditions, because if you're moving from a standard American diet of eating really processed foods like pizzas and donuts, then a keto diet is an advancement on that. It is definitely an improvement. So you will see some temporary benefits. You may lose some weight, but you are mortgaging your long-term health for any condition if you go onto a keto type diet. And I'm happy to debate this outside this forum, but I'll never get, because I mean, unfortunately, dietary wars and it's made people into literally tribal warfare on the keto front or the vegan front and so on. And it's sad because there is quite a lot of overlap in the good things between it. I mean, everybody will agree that processed food and junk food is really bad. Which is interesting because I'm going to go on to this slide, which if you look at it, it's Walter Kempner, who was quite famous in Duke University in America, introduced this diet to actually treat malignant hypertension. So it's white rice, which is very processed, all the fibers being removed, some fruit juices, which are very processed again because the fiber is removed, and white table sugar. I mean, this looks like an awfully processed diet except the fruit. But can you guess what's good about it? The good thing is that it has a 2% total fat rate. And believe it or not, this kind of a diet where you're giving people white sugar, fruit juice, and white rice was actually beneficial in diabetes and reduced insulin resistance massively. So it's just to give you an idea that even processed garbage like this was often useful, because just the fact that it wouldn't cause fat accumulation in the muscle, liver, and pancreas. Your insulin resistance actually decreased rather than increased. So people used to be critical that all diets would help diabetes if there was a weight loss. And that is a true point. I mean, even the keto diet, people will see their numbers improve remarkably, especially your blood sugar levels. Because if you avoid eating carbohydrates and you're eating really a diet full of protein and fat, very high fat diet, you will not see a rise in your glucose levels. So this paper is particularly valuable, 1979, James W. Anderson and Kylene Ward. They did this study where they really force-fed people so that they didn't lose weight on a plant-based diet. So a low-fat diet, very low-fat diet. It was 9% fat, actually. And for 16 days, they fed them and they kept making them eat so that they wouldn't lose weight. And despite that, they actually improved the insulin requirements, and it went down 58% in the low-fat diet. So 10 out of 20 patients who had type 2 diabetes stopped using insulin altogether. So it made us recognize that there are other factors such as phytonutrients and fibers in whole foods, whole plant foods, that help us control diabetes.
Rajiv, where does that leave us with the modern narrative, if I can use that horrible expression, about diabetes? It all, in the press and in everything one hears, it's all about weight loss. Is it perhaps easier to communicate to, I mean, a lot of people find weight loss very difficult, but if they can still eat in the way you've just described, then does that make controlling diabetes easier for them?
Absolutely, Stephen. Thank you for asking that question, actually, because that is the whole message that I'm trying to get across to you. You can eat in abundance, never having to starve, and get rid of your diabetes. Every diet fails because you're starving yourself, you're hungry, you'll eat your pillow at night when you're sleeping, so it's desperately depressing when you do that. Whereas the truth is that you can eat abundantly and still get rid of your diabetes. So if we move on to, that's the relevance of this particular study is because of that. Insulin resistance is as a result of ketones from fat metabolism that actually affect it, and animal protein, so meat protein or meat, eggs, dairy, all these things seem to increase insulin resistance. The ideal composition of this diet is 80 to 90% carbohydrate actually, but you're talking about complex carbohydrates bound in fiber. You're not talking about simple milled, white flour, white rice kind of carbohydrates. 5 to 10% is protein and 5 to 10% is fat. And there are four basic components. So vegetables, green leafy vegetables, cruciferous vegetables, any vegetables really, fruit, grains, and legumes, which are beans. And beans are a very important component because they have something called soluble fiber that feed our microbiome. And as you can see, nuts and seeds in small amounts, and herbs and spices liberally, because that helps to give us antioxidants. Right. So if you look at it, you can eat this whole thing. It's colorful, it's anti-heart disease, it's anti-arthritis, it's anti-aging, it's anti-diabetes. This is the kind of range of foods that you can eat liberally and get the joy. So to give the listeners an idea of what they can eat, you can start by changing each meal. So if you start with breakfast, you can eat porridge oats with nuts, with ideally a plant-based milk, berries, rye bread with avocado, a wholemeal bagel with hummus. You can eat pancakes and tofu. These are things that are available in the plant-based world. And that the picture actually shows you what Neetu and I were eating on one of our cruises that we go on, which is a plant-based cruise. So you can see that's the quantity that's Neetu's breakfast, and she's quite a slender lady who managed to tuck away all that food. So the key is that you're going for a high nutrient density, but a low calorific density. So in other words, every human being can only eat about 4 to 5 pounds of food in a day. And if you eat lower down on caloric density, you can eat as much as you like to fill yourself, and you will not put on weight. So you can eat all these things, just to give you an idea. So snacks with nuts and seeds, crudities, or crackers with hummus. Use green smoothies, fruit smoothies, you should sip slowly. So if you drink it up too quickly, you'll get a sugar high. And you can eat all these foods that I've shown pictures of very happily, So it's just to give you an idea that, people who are plant-based just don't eat white lettuce. They have a few other things to eat also. So what do we avoid? We avoid food without fiber, because fiber is so essential to feed our microbiome. So we avoid animal products, we avoid juices, oils, junk food, and highly processed food. I mean, there's universal agreement that these foods are not going to do any good for diabetes. Now, I'm going to introduce this mastering diabetes concept, which is they label foods as green light foods, amber light foods, and red light foods. And I'll give this to you, you'll be handing over these slides to your listeners anyway, but it gives you an idea that certain foods like soybean, which are very helpful otherwise on a whole food plant-based diet, are not ideal for diabetics because they're pretty high in fat actually and will increase your insulin resistance. But otherwise, it's very similar. So again, avocados are rich in fat, and so they come under amber light foods, don't have ad libitum. Whereas the green light foods, you can eat any quantity ad libitum and not affect your insulin resistance. So to give you a personal story, I mean, I was a type 2 diabetic since 2012. Pre-2017, these are some photographs of me. You can see my wife, Neetu, who's lectured to you on a few occasions in the past, and you can see I used to get these comments on how did you pull a bird like that, which was quite deeply offensive. But I had no idea that it would help if I switched to a whole food plant-based diet, which I did after watching a documentary, after not listening to Neetu, poor thing. She'd been batting away for 18 years with me. But I wouldn't listen to her. I mean, who listens to your wife after all? So,
well, we all listen to your wife.
Yes, and that's sensible. So that's just to give you a personal idea. And obviously that is n is equal to 1, but I did learn as a result of this and went on to do a lifestyle medicine course and move on. Now, just to wrap it all up, I wanted to give you some resources for your patients. So I think key is to watch this documentary, Forks Over Knives, which you can watch on Amazon Prime. I think it influenced me, and there are a number of good documentaries. The Game Changers is another one, which controversial although it was, I think it gives you a flavor of what a whole food plant-based diet is about. I found Mastering Diabetes to be an invaluable resource for anybody who's diabetic. And in Britain, you have the Diabetes Reversal Company, DRC it's called. They have an Instagram handle. They're available in London, and I think they're excellent. I think all your listeners should really join Plant-Based Health Professionals UK. I mean, it's got a very small membership fee, which all your chaps can afford, or ladies can afford comfortably. It's a great resource for health education. Nutritionists and dietitians are part of it. I've taken this opportunity to put in my daughter's name here, and another excellent dietitian, Lisa Simon, who are both part of the plant-based health professionals. But quite simply, if you get a patient who is diabetic, you should just ask them to Google whole food plant-based diet, and there's a wealth of information on the internet for them. My own Instagram handle is at Dr. Rajiv Bajekal, but really I'm an Insta newbie and I'm just getting into the mood for it. There are hundreds of other great recipes by Vegan Rich and Rainbow Plant Life on YouTube that you should watch. And I'm happy, if I'm allowed, to take a couple of questions.
Let me start with Phil. Phil has asked what role artificial sweeteners have in blood sugar spikes.
Yeah, I mean, occasionally to have a little bit of stevia, for instance, is not much of a problem. I think it's better to use dates, for instance. If you use chopped dates, it's a better natural sweetener that comes with fiber, and admittedly it will spike your blood sugar a little. But somehow artificial sweeteners seem to trick the brain into believing that it gives you a sugar hit, and it does affect blood sugars bizarrely. There's another substance called erythritol. Erythritol is Erythritol. And it's supposed to be from pear sugar, but calorifically, it's considered to be 0. It has about 2/3 the sweetness of table sugar, and it's another good thing that can be used occasionally to sweeten up food for those who want it, who want that occasional treat.
Okay. Corinne Kirby has asked about the value of olive oil, or the effect of olive oil.
Okay, well, that's a good question. I mean, olive oil is considered to be cardiac safe these days, especially if it has the phytonutrient, which is called oleocanthon. So it's, in fact, instead of calling it extra virgin olive oil, because I think everybody calls their oils extra virgin olive oil, it's better to call it oleocanthon-rich olive oil, and that has phytonutrients, and it's cardiac safe. But just one message for diabetics: any oil is 9 calories per gram. So if you use a tablespoon of olive oil, you put in 120 calories into your food. So remember, it's just a spoonful, and it's going to disappear in the interstices of your diet, and it adds 120 calories. So in general, diabetics better avoid any oil, but olive oil is probably the most helpful of them. Certainly don't drizzle it on your salad. It's madness to do that. I think if you're eating a standard American diet, it's excusable to use a bit of olive oil. It's still more helpful than the other stuff that they eat. But I'm not a great fan of olive oil purely because it gives the message that olive oil, any amount is fine, and that's the wrong message.
Okay. Trevor has asked whether intermittent hypoxic training assists with prediabetes.
Can you ask the question again, Stephen?
Yeah, he's asked whether intermittent hypoxic training assists with prediabetes.
I haven't come across any literature in this regard. That's presumably training at high altitudes and things like that. I
Yes,
don't know.
Or simulated high altitudes, I imagine, yes.
Right. No idea at all.
Another one is, in your thing about diet earlier on, you said only small amounts of nuts and seeds, and someone has asked why only small amounts.
Because for the same reason that they're high calorific density. So nuts and seeds, I mean, I'm a nut addict. And if I see a packet of cashew nuts or salted peanuts, probably I'm a salt and a nut addict. So I can go through a packet of 200 grams in no time. And that's massive in terms of a caloric yield, so it's better to just eat a small handful and ideally not roasted or salted, because you can get through a bag full. And if you remember, if you eat the whole food, you actually have to crack the shell of, nuts to get at the nut. Now it's readily available, and the nut industry serves it out liberally salted, and you can put on a lot of weight and increase your insulin resistance if you consume them in big quantities.
Perhaps I can just wind up with a couple of questions. One that's come in from one of the audience. Kenneth has asked if you have any views on the new NHS programme on tackling diabetes.
I haven't read it in great detail, but I think somehow the NHS tends to find this pathway of moderation being a good thing, because they don't want to make radical changes. And I don't think everybody needs to make a radical change, but I think from a patient perspective, they should be offered the correct choices. And the choice should be really to go in the direction that Japan has gone. So Japan says 13 portions of fruit and vegetable. I mean, we're still lingering around the 5 and we barely manage it. And that is the way to actually make a substantial difference. And also not to serve the kind of garbage that they serve in hospitals. I mean, if you enter my hospital, all the kind of foods that I said you mustn't have are served in the hospital. And I think hospitals at least should serve healthful food, salads and soups, no problem. But really, should we be eating burgers in a hospital? I mean, you can go home and eat as many burgers as you wish. But just as they don't allow smoking inside a hospital or in the perimeter of the hospital, they shouldn't really allow unhealthful food in.
Well, I suppose that leads me on to my final question, which is how much of the advice that you've provided us with that we can give to our patients is going to be controversial? Will we find that the local GP is complaining that we're giving improper advice to our patients?
It's a very good question, Stephen, and it's the reason why I did lifestyle medicine, because if you want to tell people the truth, you have to back it up with science.
Yes.
And that's why I have put some of those resources, and all the resources are actually backed up by really hardcore science. They're well-validated papers, there are well-validated studies, quite unlike pulling the wool over somebody's eyes by doing studies that are that get past peer review publications and get published, but really don't have scientific backing. So I would say if you provide this, in fact, it's down to patients to educate their doctors. If they reverse their diabetes and prove it in that way to the doctor will have to follow suit.
Okay. Rajiv, you've been very generous with your time as always and with all your information. I'm really grateful to you for coming on the show like this, and I'm sure many of our viewers are as well, because that's all wonderful stuff that we can share with our patients. And I'm hopeful that we'll get you on the show again in the not too distant future for more of the same stuff.
Thank you. Thank you very much, Steve.
And give our regards to Neetu as well, please.
I will do. Thank you.